Okay, here's the first case for tonight. The diagnosis is actinic keratosis. Actually, it is a intraepidermal keratinocytic atypia, also due to sun damage. So we can see some solid elastosis in the dermis, and then it is also considered as a precursor of squamous cell carcinoma. So the key finding for the diagnosis of this entity is that even in low power, we can see this kind of Baker cell. We know this is atypia. Why I say this is atypia, we can compare to kind of relatively normal keratinocytes in the basal layer. See, they really well organized, do not have loss of polarity. They do not get really big. So this is relatively normal. Then when you come down here, we can see the cell is get bigger. Here is one of the signs just like a eyeliner. So these cells are normal. These are atypical cell. So if the atypical cell just focus on the lower 1/3 or 2/3, not fully atypia of all the epidermis, this is really good for actinic keratosis. And then in low power, another sign is that we can see some parakeratosis, orthokeratosis, parakeratosis. This is kind of like a flag. We call this is flag sign. So when you see flag sign, some para, ortho, and then underneath you can see this atypia. That is actinic keratosis. And there are several variants for actinic keratosis. Let's show you one more. This is the gross skin picture of actinic keratosis. This is one of the variants. We can see how thickness of the epidermis and the parakeratosis, hyperkeratosis. So this is a plaque. This is the hyperkeratotic actinic keratosis. Let's see what's the microscopic finding. Even low power, we can see really thickened stratum corneum, hyperkeratosis. And if we zoom higher, we can see tons of nucleus here. This is parakeratosis, not just hyperkeratosis. And then around the follicle, we have this orthokeratosis, but between the follicle, we can see really nice nucleus. So this is orthopara, really nice flag sign. And let's look at the atypia. This one, why we call this hypertrophic actinic keratosis, because the epidermis kind of thicker, almost kind of like psoriasiform hyperplasia. So we can see this really kind of thicker elongation, and whole epidermis is thickening. But when we see the cytology of the cell, they typically still in the lower part of the epidermis. They do not have full thickness epidermis atypia, so not reach to the squamous cell carcinoma in situ. So if you can see atypia at the bottom, acanthosis of the epidermis, nice flag sign. This is hypertrophic actinic keratosis, and really nice sun damage dermis, solar elastosis here. So this is hypertrophic actinic keratosis. Next case. Low power, we can see parakeratosis here, tons of hyperkeratosis, and then we can see even this low power, we didn't zoom in, we already see this really atypical cell, really hyperchromatic, really dark, and also big. but the low power express the impression also kind of really hypercellular. In a normal epidermis, you won't get this turn of cells. So even in this 2x low power, you already suspicious of full thickness of atypia, like squamous cell carcinoma in situ. If you don't believe me, I can give you a high power to see from the basal cell layer. We can see the cell loss of polarity, really dark, hyperchromatic. They just have hepatitis growth, really atypical cell, not only just focus on the basal cell layer. And then in terms of mitosis, apoptotic cells, really ugly cells, keratinocytes, mitosis everywhere. And then they have this full thickness. If this squamous cell carcinoma in situ is happened in the scrotum, we will call Bournois papulosis. But if in other skin area, we will call squamous cell carcinoma in situ. So you can see really through thickness atypia, mitosis everywhere. Let's see one more case. This case, low power, you may also think of really hyperkeratosis, parakeratosis, almost look like a flag sign. So maybe just highly suspicious for AK, actinic keratosis, or even hypertrophic AK. But a little bit higher power, we can see some bigger cell forming like this pagetoid spread. Pagetoid spread, that means the atypical cell just go to single cell in the epidermis. And the differential diagnosis of pagetoid spreads in derm path. First, we just like this case, squamous cell carcinoma in situ. Another one is melanoma. And the other one is kind of rare, that is merkel cell. We can see kind of the atypical cell go to the epidermis, and also sebaceous carcinoma, they also have their in situ components, also can have this pagetoid cell. And if in the breast, we also need to know mammary Paget's disease, also they have this pagetoid spread. But when we look at high power, this is just squamous cell keratinocytes, really big keratinocytes. And then they have the atypia, not just in the bottom, but it also go into the full thickness. They lose their granular cell layer. They have pagetoid cell even go this high up. So this is another squamous cell carcinoma in situ. I'm going to skip the traditional classic squamous cell carcinoma because I know everyone, when you see the diagnosis, you know that it's squamous cell carcinoma. Here is kind of a variant of squamous cell carcinoma, keratoacanthoma type. If this is a true keratoacanthoma, usually we don't need to treat this kind of lesion because this lesion classically grows really fast, and then they will regress by themselves. For a classic keratoacanthoma, we need to see this kind of volcano surface with this hyper or parakeratosis. And then at the bottom, we just can see tons of inflammation, and then this squamous cell not really budding out, not truly invasive. You can see this budding out, but this is not truly budding out. If we cut deeper level, this next and this next probably just connect to the epidermis. And then when you try to diagnose this keratoacanthoma, you could not see really dramatic atypia. If you see really dramatic atypia, that should be squamous cell carcinoma, not keratoacanthoma. Another thing is that in keratoacanthoma, we also can see tons of inflammation, including neutrophil in the epidermis. And also, sometimes you may see neutrophil forming microabscesses for the keratoacanthoma. So, but if you are not sure, just call it squamous cell carcinoma keratoacanthoma type. Next case. I think this one is really easy. Everyone knows the diagnosis. This is basal cell carcinoma. I just show you this classic picture. This one is nodular type. You can see forming this nodule. The classic finding is that even low power, we can know this retraction artifact. That means this nodule have kind of this separation between the stroma. And then stroma kind of bluish looking. That is classic basal cell carcinoma stroma. Bluish like mucinous material. And then mucinous material, they may have this bluish mucinous material around this blue nodule or even inside the carcinoma. And then classic basal cell carcinoma, we can see this palisading, hyperchromatic basaloid cell. So when you see retraction side effect, mucin between the nodule and the stroma, also the stroma is also bluish mucin, intracellular mucin like this. That is basal cell carcinoma. Here's the skin photo of basal cell carcinoma. You can see it's kind of a papule, kind of reddish, looks like really easy to bleed. So this is basal cell carcinoma. And then here is another basal cell carcinoma, but this is another subtype that is the infiltrative type. So we can see all the classic findings for basal cell, like mucin, intracellular mucin, and kind of subtraction artifact between the stroma and the palisading basaloid cell here. Then, but we can see this next, just not forming next. They have this infiltrated growth like this. So usually the dermatology will check this infiltrated growth basal cell carcinoma, doing a surgery to just make sure to take it out. Here's another variant called fibroepithelioma of Pincus basal cell carcinoma. This is a dome-shaped nodule pushing out from the skin. Then they forming this kind of anastomosing, almost like neck structure. And then they do not have classic basal cell carcinoma stroma, not really mucin bluish. But when we zoom in, we can see this basaloid palisading cell. They're not forming this nest, they're just forming this strange anastomosing structure, and then kind of mucin inside this area. You could not find any aqueduct because there is another mimicker called the serenocystic adenoma. You may see aqueduct in that entity. So this is just another variant of basal cell. You can see basaloid palisading cell in the periphery with this mucinous stroma inside, kind of subtraction artifact. So they have also have some feature of classic basal cell carcinoma. I put this one as a differential diagnosis for basal cell because usually you will also have this kind of lesion. Usually happen this is called trichoepithelioma, usually in the head and neck face area. Why we do not think this is basal cell? First, usually these benign tumor do not attack the epidermis, so it's just stay in the dermis. And then when you look at the stroma, it's kind of different from the mucinous bluish stroma of the basal cell. You can see this is a hair follicle, so the stroma just like pink, not bluish, just like the normal stroma around the normal hair follicle. So this is, and then the cell kind of look like basal cell carcinoma, but they look really blank. In basal cell carcinoma, usually you can find kind of atypia and also some mitotic figure in the basal cell carcinoma. But in this benign entity, you usually do not see that. And then we need to find, some people may say, oh, this is retraction side effect. But when you look more detail, actually it's not. This kind of subtraction just between the stroma, not the stroma and the basaloid nodule, not the stroma with the basaloid cell. So this is not truly retraction side effect. And then there is classic feature why we are sure this is trichoepithelioma, because we have this kind of structure, basaloid cell surrounding by this spindly mesenchymal fibroblast-like cell. We call this mesenchymal papillary mesenchymal body. When we have this papillary mesenchymal body, that is trichoepithelioma. But whatever, if you diagnose something like basal cell for a trichoepithelioma, I think even you have this kind of nodule in your face, you still want to take it out. But remember papillary mesenchymal body, that is this basaloid cell hugging by this spindle fibroblast-like cell. This is a classic feature. When you see this feature, you are sure that is not basal cell carcinoma, papillary mesenchymal body. If you're really not sure, you can do one staining to help you. That is CK20. CK20 can highlight the passenger merkel cell, because in benign lesion, there should be some merkel cell around. So when you do CK20, you can highlight single individual CK20 positive mesenchymal passenger merkel cell around. That is really good for a benign entity trichoepithelioma. And the other people will also kind of confused with trichoblastoma. Actually, trichoepithelioma and trichoblastoma, they are in the same family. For me, if we can see kind of like small lesion like this one, I would say this is trichoepithelioma in the superficial dermis. This is another one, trichoepithelioma. Even in low power, even we see this basaloid nodule, but this pinkish stroma really take you apart from basal cell carcinoma. And then this is retraction side effect, not as similar as the basal cell carcinoma. This is not true retraction side effect, because this retraction is between the stroma, not between the basaloid cell and the pinkish stroma. Then we want to see our friends papillary mesenchymal body. This one is really nice basal cell hugging by this spindle fibroblast-like cell, papillary mesenchymal body. And then remember, we can do CK20 to highlight the passenger Merkel cell. Here, the reason I want to show you this one because the name looks like really similar. This one is desmoplastic trichoepithelioma. Even they have the same name of trichoepithelioma, but in the microscope they are totally different because desmoplastic trichoep fall into the tadpole pattern. I think we will have that typo pattern differential diagnosis in the later cases. This is the basal type or tadpole pattern. That is this line structure. Tadpole, we have the head and then we have the tail. We have the head and then we have the tail. Somewhat like this, if you have the head and then you have the tail, this is the basal type pattern. When you have this pattern, we call this desmoplastic trichoep. Because for this pattern, there are several differential diagnoses. One is basal cell carcinoma, the other one desmoplastic trichoep, third one subsyringoma, and then the fourth is macrocystic annexal carcinoma. How could you tell them apart? First, for desmoplastic trichoep, you do not see perfectly like this rung and then with a tail. You usually do not see that. That is one feature for desmoplastic trichoep. Sometimes you will see calcification, those we do not see here. And then this lesion do not go down deep and then kind of well circumscribed. If we go really down deep, even into the muscle and subcutaneous, that is macrocystic annexal carcinoma. But even like this, if you have this lesion, you still want to take it out because usually it's really broad shape and then really not really to tell them apart. So this one just for your information, like desmoplastic trichoep is not similar to just trichoepithelioma. Then next entity, this is the Merkel cell carcinoma. Why I say that low power, we can see this lesion maybe in the head and neck, face, or maybe scalp, because we can see the hair follicle with deep down in the subcute, and then this big bluish nodule. Then when we zoom in, it's really identical to our small blue cell differential diagnosis. The cell is really busy, really hyperchromatic. You can see tons of apoptosis, really easy to find apoptosis. And then also mitotic figure is everywhere, so you know this is really high grade. And that cell with really hyperchromasia and then really hypercellular. Sometimes just almost like molding together and then didn't form any distinct structure, just this nodule and sheets of cells. But when you have this pattern, you really need to do punch of staining for the diagnosis, because for small round blue cell, we have tons of differential diagnosis. Merkel cell is estimated like the primary tumor of the skin. And then we have other metastases, even like small cell carcinoma from the lung, and then maybe also other neuroendocrine carcinoma from anywhere else. So we need to do the staining. For the classic Merkel cell carcinoma, that is CK20. We have the slide here, that is CK20. The classic pattern is this dot light positive. Of course, you can have cytoplasmics and membranes staining, but the classic one is this dot light. And then CK7 negative. You can also do Merkel cell polyoma virus that is really specific but not really sensitive at all. Around maybe around 60% of Merkel cell carcinoma, you may have that MPV virus positive. So if positive, it is really helpful, but if negative, you could not rule out Merkel cell. And then we can also do TTF1. TTF1 usually negative, but in our lung primary, TTF1 should be positive. Then here's another entity, even low power, which catch our eye, this bubbly cell. It seems just around the hair follicle, but we just have too many this structure. This is sebaceous gland. So when we have more sebaceous gland than usual, we have our differential. This one just sebaceous hyperplasia. Why another one is sebaceous adenoma or maybe sebaceoma? How could we tell them apart? First, for sebaceous hyperplasia, this sebaceous gland just hugging a hair follicle. And then when we have high power, we just can see most of these structure just sebaceous cells. And then in the periphery, we do not see germinative stem cell. That means germinative stem cell, just like this cell, usually in sebaceous hyperplasia, just single layer of this hyperchromatic basaloid cell. If we have several multiple layer, that is at least sebaceous adenoma. So this one just sebaceous hyperplasia. And then we have sebaceous adenoma. This is sebaceous adenoma. First, we know that this sebaceous can not just surround the hair follicle. They just everywhere. Then, even low power, we know other than this bubbly sebaceous gland, we have kind of multi-layer of this hyperchromatic, multi-layer bluish basaloid cell. When we zoom in, yes, we can see not just sebaceous differentiation around. We also have this hyperchromatic cell, multiple layer of them. And then when you call this sebaceous adenoma, that means you will have more than 50% of this clear sebaceous well-differentiated sebaceous cells. If we have more this primitive germinative basaloid cell, more than 50%, we call that sebaceoma. And then you need to bear in mind that for this sebaceous adenoma and sebaceoma, we need to see kind of well circumscribed. We could not see that infiltrated growth. And then when we see the cytology, sometimes you may see mitosis, but you could not see atypical mitosis. Kind of a little bit atypia, but not dramatic atypia. This is sebaceoma. Even low power, we can tell we have some kind of sebaceous differentiation, bubbly cell, but other than that, we have more of this basaloid, primitive, hyperchromatic cells around. But the overall architecture kind of draw a line here, kind of symmetric, well, kind of circumscribed, and then higher power, we really look for any dramatic atypia. We have a little bit atypia, but not really dramatic. And then occasionally, you may find mitotic figure, just like this one, really clear mitotic figure. But not infiltrated growth, not really dramatic atypia, and then you should not find any atypical mitosis. So this one is sebaceoma. Then we have this sebaceous carcinoma. This lesion is really big. Even in this part, we can see the lesion kind of like dissected. So you can estimate this is really infiltrated lesion, and then really dark, really hypercellular, hyperchromatic. And then in some area we can still see this sebaceous differentiation. But when we see this cell with this stroma kind of infiltrated growth, then let's see the cytology of this cell. With some cell is really big, really hyperchromatic. Just atypia just make you think of it should not be benign entity. In combination of the infiltrated growth, this slide is not that really high resolution. But you can see this cell is kind of really atypical, really big compared to this one. So you need to think of sebaceous carcinoma. And then when you have multiple of these sebaceous adenoma, sebaceoma, sebaceous carcinoma, and this lesion usually happen in the face, head and neck area. If you have multiple, you do need to think about Merkel syndrome. That is another variant of a small subset variant of Lynch syndrome. So you can do your microsatellite marker MLH1, MSH6, MSH2, PMS2 to just screen to Merkel syndrome. And then especially if you see sebaceous adenoma, sebaceous sebaceoma, sebaceous carcinoma out of head and neck area. Even one single lesion, really highly suspicious for Merkel syndrome. But sebaceous hyperplasia is not foreign to the Merkel entity. So if you think that is sebaceous hyperplasia, that's totally benign, not related to any syndrome. Then let's see the growth picture of this entity, kind of a plaque. But you can see this single individual small undulated surface. You can see just really highly matched to the gross skin picture, kind of this papillomatosis indurated surface. Then even low power, you know it should be in the head and neck area, really deep down hair follicle. Then the subcutaneous fat is really thin. I mean, the distance from the subcutaneous fat to epidermis is really short. Then we have this deep down hair follicle. What really catches your eye is this sebaceous gland. Usually sebaceous gland is connected to the hair follicle, but this sebaceous gland is not. It kind of connect to the epidermis, not connect to the hair follicle. You can see connect to the epidermis and then turn surface. And then another feature from low power, that is you can see hair follicle, hair follicle, hair follicle, and then all of this area we could not see any hair follicle, just kind of naked. That's the reason this lesion is kind of a hematoma. Then in the two sides of this lesion, you can see this hair follicle. So this is nevus spacious. Another feature for nevus spacious is that we will see this kind of gland. This is not acri gland. This is kind of hobnail looking, really pinkish cytoplasm. Sometimes high power, we can see this prominent nucleoli. This is apocrine gland. So usually in nevus species, you will find this apocrine gland. And then even more weird thing is that if in a older patient, you may find other lesion like sebaceous cell carcinoma, but not sebaceous cell. That is basal cell carcinoma in the cervix occasionally. And also you can find scalp, syringocystic adenoma papilliform. Also, you can find this several diagnoses in nevus species. I think they are not lack of etiology of each other, but they just come together. So just quickly recap. When you see tons of sebaceous gland, do not open to hair follicle, just open to the surface of the epidermis. And then around the sebaceous gland, no hair follicle. But just besides this hematoma, you can find normal hair follicle. That's really good so for nevus.